Okay, let's move on to the shoulder, which is the second toughest joint after the hip. I've broken it down by projection. The coronal projection is the marquee projection. It's got all the fame and all the glory. You should have a T1 and some heavily water-weighted sequence, preferably a PD spur, spare, or special. Optional would be a coronal T2 with fat suppression, not mandatory. In the sagittal projection, I like to mix it up, and there I'll get my sagittal T2 with fat suppression. Usually only one axial as a scout unless there's a history of dislocation. And the axial is dealer's choice. It can be a gradient echo, 2D, 3D, T1, and even a T2 high resolution. My least favorite in the axial projection. The coronal affords you the ability to see the ever abnormal AC joint. Nobody has a normal AC joint. It's not meant to last more than 15 years. It is a common cause of shoulder pain. It is a common cause of slap lesion repairs that didn't need to occur. It's the view for the rotator cuff, for the biceps labral anchor, the inferior glenohumeral ligament, the subacromial space arch. We'll talk about the medial, lateral, and anterior arches. It allows you to characterize the slap lesions 1 through 12. And we'll talk about the rules of labral evaluation momentarily. The coronal allows you to see the conformity and relationship of the humeral head to the glenoid cup for superior decentering when you're lying down of the humeral head relative to the cup is a poor prognostic sign in patients with rotator cuff disease who are being considered for surgery. It's also a view that allows introspection and reflection of the brachial plexus, the axial. It's the view for the labrum, specifically the anterior labrum, and we'll talk about the top-down rule, where the anomalies and variations in the labrum are in the upper quadrant, and the consistent anatomy is in the lower quadrant. The axial allows you to view the rotator interval space. It's also another view for the rotator cuff, which includes supraspinatus, infraspinatus, teres minor, subscapularis, biceps, and coracohumeral ligament. It allows you to see the various types of labral tears and characterize them in front or in back, and is a supplementary view for the biceps labral anchor and the most important view for the middle glenohumeral ligament and the superior glenohumeral ligament. It's also your view to look for coracoid abutment, to see injuries of the coracoid and injuries of structures that are attaching to or have origin from the coracoid, like the coracobrachialis and biceps shorthead. The axial also allows you to see centering of the humeral head. So decentering in the axial projection is usually not from rotator cuff insufficiency. It's usually from uni or multidirectional instability affecting the capsulolabral mechanism. So centering, decentering coronally and decentering axially have different meanings. Sagittally, the rotator cuff tear length is assessed. This is also the best projection for assessing infraspinatus tears. It allows you to assess the shape and character of the acromion, the glenoid fossa, the biceps pulley mechanism, the Hill-Sachs abnormality, and affords you the ability to do on-track, off-track measurements to see if there is engagement of the humeral head against the glenoid cup, a subject that we will discuss this morning or this afternoon in patients with recurrent dislocation. The sagittal is also a reasonable view for the scapula and to look for chronic calcific labral pathology such as the Bennett lesion. Now I've got a few quick slides I want to share with you. The glenoid cup is pear-shaped. When you're looking at tears in this pear-shaped structure and you clock face it not straight up and down orthogonally, you take it in its widest dimension. So your clock face A to P would be here, and your vertical clock face would be here. I've also drawn a clock face for you on an MR. So it's not going to be a straight up and down. Most people use the anterior as 3 o'clock and the posterior as 9 o'clock. Irregardless of how you clock face your tears, you should always give them a quadrant. 3 o'clock anteromid, 9 o'clock posteromid, 12 o'clock superior, and so on. There is an area in the glenoid that is relatively devoid of cartilage, or very thin, known as the bare spot. Occasionally, there is a notch in this area within the cortical bone, known as the notch of Osaki. It is not associated with any edema or swelling. It is centrally located. It's symmetric. It's well corticated and shouldn't be confused with an OCD. We have already talked about the configuration of the rotator cuff and how it's divided up into a stiff cable and a more lax crescent. And some individuals are crescent dominant and some individuals are cable dominant. And this will determine to some degree what tears do after they occur. The footprint of the rotator cuff is complex. It has a broad footprint. The infraspinatus slides underneath the supraspinatus. So they intertwine anteriorly, but it doesn't go quite as far forward. The supraspinatus can also send fibers over to the lesser tuberosity. Rarely, the infraspinatus sends a few fibers over to the lesser tuberosity of the humerus. Tears in this location are not articular-sided tears. There's no joint space here. They're humeral-sided tears. If they occur right here, you can't see them. They're concealed. They're hidden. They're often called concealed interstitial delamination tears, or CIDs. Tears over here are articular-sided. This area has no cartilage. It's called the bare area. This would be a bare area articular-sided tear here. This would be an articular-sided tear. This would be a humeral-sided tear. These would be bursal-sided tears on the superficial surface. I'm going to stop right there, and I will come back when we show some dislocations and talk about on-track and off-track measurements of the shoulder. Let's look at some cases, and then I'm going to bounce back and forth and show you some different nomenclatures for each of these different types of pathology. Let's go. So I usually start my shoulder evaluation with the axial because that's what comes up first. I am looking at the shape of the glenoid cup. How deep is it? Is there retroversion or anteversion? What does that mean? Well, if I draw a line down the scapular spine, and then I draw a line from the anterior aspect of the glenoid to the posterior aspect of the glenoid, it should be about perpendicular to that line. Now, if I automatically draw a perpendicular line that's perfectly perpendicular, and then I draw that other line, I'll have an angle. And that angle should be about 6 degrees, no greater. Let me redraw it now. What if I had a situation where the anterior labrum was over here and the posterior labrum was over here? Now I will take my perpendicular line, and I'll take this line between the anterior labrum and the posterior labrum, and I'll make an angle. Now I have a retroversion angle. What if my glenoid cup was sticking out in the back more than the front? Then I would be forcing the humeral head forward, and I would have an anteversion posture of the glenoid cup. So I am looking at the posture of the cup, the relationship of the anterior glenoid to the posterior glenoid, the depth of the cup relative to the size of the humeral head, and how the head is sitting with the patient lying on their back relative to the glenoid. This one is sagging just a bit. You put a little dot in the middle here, put a dot in the center, you put a dot in the center here. It's just off center a little bit. Should be a little further forward. Not uncommon as you get older. All right, so let's keep scrolling. In this projection, I look at the rotator interval. Here's the interval. Here's the biceps labral anchor. You're seeing the base of the superior glenohumeral ligament. You can follow the biceps into the bicipital groove. You can see the biceps pulley mechanism complex, which consists of the coracohumeral ligament, the subscapularis, the biceps, and we don't see the superior glenohumeral ligament at this level. Let's keep going down. Up high, it's not uncommon to see spaces between the labra and the underlying bone, but down low, it should tighten up very nicely, and it does. We can see the straight middle glenohumeral ligament, the more arc-shaped anterior band of the inferior glenohumeral ligament, and the posterior band of the inferior glenohumeral ligament, and the axillary band of the inferior glenohumeral ligament. As we mentioned in our introductory slide, we do see the rotator cuff in the axial projection. There it is. This is supra and infraspinatus. This is subscapularis. We see the biceps. We see the coracohumeral ligament. We see the teres down lower. We have the entire rotator cuff mechanism in the axial. Now, it wouldn't take that long to go through it. We also have the coracoid and the size of the coracoid arch. It's not something you measure. It's something you observe to see if there is swelling or compression of the structures behind it. Let's go to the coronal. I will put up my coronals immediately thereafter together, all of them. If there's 2, they go up. If there's 3, they go up. I take a quick glance at the AC joint because it's always abnormal. When am I interested in it? When they have pain on top, when the spurs are massive, and specifically when the T2 spin echo has an effusion. Not the PD spur, not the stir, not the spare, not the gradient echo. They'll all be bright, but the T2. So if the T2 is bright, it has meaning. This is not a T2, it's a PD. So there is some swelling in the AC joint, but everybody's got that. So we've got our supraspinatus, our infraspinatus in the back, our subscapularis in the front. We'll ignore our teres temporarily. We're looking at our overall muscularity to see if there is volumetric reduction in muscular size. Is there fatty replacement of muscles? No. Is there a superior labral tear? Not one that's symptomatic. There are fissures and signals in the superior labrum commonly, but they shouldn't be prominent in the posterior superior quadrant of the shoulder. They're non-full thickness. They usually, these sulci in this area arc medially, and they don't penetrate out the top. They're not associated with cysts, and they dissipate in the back. So as you go from front to back, signals become less conspicuous posteriorly. The sulcus, or normal variations, are found in the front. They bend medially, and they're round on top. What about decentering? We look at the arc of the humerus, and we like that arc, that drop-off, to sit right along the inferior aspect of the bone. So that should line up with that. So there's a little bit of superior humeral decentering. So now let's turn our attention to the rotator cuff. What are we going to call this? I'm sure everybody has identified signal alterations in the rotator cuff, but it's all about what words to use. So what words are we going to use? Medially, there is an area of ill-defined signal intensity along the articular surface of the cuff, right, medial to the footprint in the bare area. So we would say there's tendinopathy with an ill-defined bare area under surface partial thickness tear. Now that is different than this. Can you all see the difference in the signal of this smudgy white signal compared with that razor-sharp, hyper-intense signal? This is what a chronic or subacute abnormality looks like. This is what an active abnormality looks like. This one is in the rotator cuff footprint. It has a slight lateral shape to it. In other words, it looks a little bit like a bird, kind of like that. Some people refer to this as the gull wing sign. And it's a sign of a superficial, bursal-sided rotator cuff tear. Is it a surgical tear? No, it is not a surgical tear. These tears heal on their own. 10 years ago, it might have been a surgical tear. We now know that these patients do better with conservative management. So MR is integral in deciding who goes to surgery and who doesn't based on muscle size, decentering, thickness of the tear, length of the tear, the extent of retraction, etc. Because shoulder surgery is a big deal. So what do we have? Conclusion. Number one, gull wing sign, consistent with a 4 by 3 by 5 millimeter, less than 50% depth, rotator cuff, bursal-sided, footprint, active tear. I'm going to put the articular-sided abnormality in the body of the report, and in that respect, have the clinician pay less attention to it. Now, how does a patient get such a tear? Usually by arm abduction. So the tear is created by impaction against the undersurface of the acromion, even though the acromion in this patient is not terribly misshapen. The sagittal. Let's look at our acromion. Might have a little bit of a point or hook to it, but most of the time these are positional. In other words, when the patient picks their arm up, the humeral head doesn't stay centered. It elevates, it impacts, and shears the superficial portion of the cuff. Here's the tear in the AP projection, and it's got an AP dimension of 1 centimeter. So a little bigger than we described earlier. It's got a transverse medial-lateral dimension of 6 millimeters. So we'd say 6 millimeters wide by 10 millimeters AP, superficial, bursal-sided tear. Gull wing sign. Next. The question is, do you ever get tears in the subscapularis muscle or tendon? You commonly get tears in the subscapularis muscle and tendon. Especially right here at the medial attachment. I'm going to show you some diagrams of the biceps pulley mechanism. This structure has a large role to play in preventing the biceps from subluxing medially, and this area right here is the most prone to tear, right at the attachment of the lesser tuberosity. There are also superficial fibers, which you can see here, that continue on and blend with the coracohumeral ligament and form the hood or roof of the biceps canal. So that can tear too. But the most common isolated biceps tear is here. You can also tear the whole thing. When you do, the biceps starts to come out of the bicipital groove. How it comes out depends on whether you tear this, or both. 41-year-old female. Says, evaluate for bursitis, tendinitis, complete tear of the biceps, or slap lesion. In other words, rule out everything. Please figure it out for me. Now, I don't want to go through the entire search pattern on this one. I put it in only because the patient is very large, 340 pounds. This was done on an oval. But the axial with fat suppression is a gradient echo, and it shows you where all the highlighted swelling is. So it allows you to go immediately, just for expediency. I wanted to show you how you could get through a nasty case like this. You go right to the water-weighted image, and you know where the pathology is. You cross-reference it. You go to the coronal image, and now you have the pathology right in your sight. So now you're really left with what to name it. Now, this is a huge woman. You better have some serious pathology if you're considering surgical intervention. So the question that's often asked is the rotator cuff tear full thickness? And you know what? The answer is, it actually doesn't matter. It matters how deep it is. It matters how long it is. It matters how wide it is. It matters what the muscular size is. And it matters whether the patient is a surgical candidate. Let's look at her muscles. They're moderately small, and they have fatty infiltration. We grade them, 1 through 3. Muscle size should be about a 2. We grade fatty infiltration. In the deltoid and trapezius, she'd be about a 1 or a 2. So based on muscularity, she is marginally a surgical candidate. Based on her body type, she is marginally a surgical candidate. So I am going to dumb down my read of this tear, even though it is a deep tear. So how would I describe it? It is a confluent area of tendinopathy that involves the bare area and medial portion of the cuff with a focal area of deep penetration that is either full or near full thickness, exiting the bursal surface as a potential pinhole with peritendinitis. And that's it. And I'm going to let them decide from there. The only teaching point in this case is large patient, not great imaging, go to the water-weighted image, find the hot spot, and then drill into the rest of the findings. All right, let's move on to the next one. And by the way, if this patient did have surgery and that was a communicating tear and it was a pinhole tear, it had a 1.5 millimeter area of communication right there. Eight weeks of pain. It's a man. He's 50. Start with the axial. Some better image quality. Rotator cuff, supraspinatus, infraspinatus. Biceps labral anchor. Teres in the back. Subscap in the front. It's tendinopathic. There's some signal in it. The biceps is slightly medialized. So there is an injury to the deep fibers of the subscapularis, allowing the biceps to sublux slightly. Up high, rotator interval. Up high, superior glenohumeral ligament. Paralleling the subscapularis is the middle glenohumeral ligament. Down low, more arc-like, the inferior glenohumeral ligament. The anterior labrum, the posterior labrum, the posterior capsule. The transverse humeral ligament, formed primarily by the coracohumeral ligament and the subscapularis. Let's go to the coronals. Rotator cuff, it's a little gray on T1. There's no focal, well-defined, serrated, marginated, high signal intensity within. Muscularity, good. Fatty infiltration, none. Decentering, slightly. It should be down just a little further, but not much. Pretty well centered. Conformity, good. Supraspinatus, intact. Infraspinatus, intact. Subscapularis, we already said it was a little swollen, but no major tears. AC joint, unimpressive. In fact, fantastic. Coracoclavicular ligaments, normal. Posteromedial conoid, anterolateral trapezoid, intact. Superior labrum, normal. Inferior labrum, kind of gray. Inferoaxillary glenohumeral ligament, kind of gray. Rotator interval up higher, kind of gray. Let's look at the sagittal. I had the wonderful opportunity of going to Nashville and seeing the total eclipse in totality. It was amazing. It's the first one I've ever seen in my life. The lights came on in the city, the birds started chirping, the grasshoppers started jumping, and people were screaming and clapping all over the city. And you could see a little spot of light around the edge of the sun as it shone through the eclipse. And so too can you see a spot of light right around the glenoid cup, all the way around the solar eclipse sign of adhesive capsulitis. Now, who gets adhesive capsulitis? Not men. And certainly not young men and not muscular men. But sometimes stuff happens. So, wrong sex, wrong age, wrong body type, but yet he still has fibroinflammatory capsulitis. Now, what happens in fibroinflammatory capsulitis? You get contraction of the joint and decreased range of motion, which he does have. I left that history out intentionally. You squeeze the fluid to the front, to the back, or into the bicep sheath, but it stays away from the center where the contraction is. The inflammation is usually most consistently seen in the axillary recess. The second most common location is in the rotator interval. The patients often describe decreased range of motion, but sometimes all they describe is a zinging, tingling sensation going down their arm because all the fluid that has been squeezed into the biceps creates secondary biceps tenosynovitis or peritendinitis. So that can be a very misleading part of the history. Another common mistake with this disorder is to say the patient has tendinopathy or even a tear of the rotator cuff because the rotator cuff is gray. This condition infiltrates everything. It infiltrates ligaments, it infiltrates tendons, it even infiltrates recesses. So a common mistake I see is people reading SLAP lesions because you have a sulcus, you might have a normal sulcus, say there was one right here, and it fills in with this bright material. And the person says, oh my God, what's that bright thing in that sulcus? It must be a tear. No, it's fibro-inflammatory tissue creeping around the shoulder in the condition known as ADCAP, adhesive capsulitis. So this is a clinical diagnosis. Your clinician will tell you that. But it's a radiographic diagnosis now too. So how do I handle it? My conclusion would read, diffuse fibro-inflammatory capsulitis, predominantly dry, with fluid expressed eccentrically into the anterior recess and biceps, most compatible with fibro-inflammatory capsulitis and consistent with the clinical syndrome of adhesive capsulitis. Shall we do another? Shouldn't have happened, but it did. Collision injury. Study is done completely without arthrographic injection. We have an arthrogram because there is blood and fluid in the joint, so we don't need to put any gadolinium in there. We already have it. It's a complex case. I'll give you a moment. I really would like you to make some independent decisions. And while you're doing that, I'm going to draw for you. So I'm looking at the glenoid cup in the sagittal projection. My axis would be here and here for my clock face position, not here and here. Does everybody get that? Pretty simple. I'm going to draw some more while you're looking. You can look up, you can look down, keep scrolling. It's a complex case. I'll make a circle, a best fit circle around the glenoid cup. I will then measure the diameter of that circle from anterior to posterior. If I am missing a piece of bone, or if I have deficiency here, which in this case I do not, but if I did, let's say I was missing a piece of bone about that size, I would measure it. Take a measurement of it. And then I would subtract that from this. So I take my red line, let's say that's 25 millimeters, and this bone loss was 4 millimeters. Now I'd be left with 21 millimeters. Everybody got that? You with me? Then I multiply that by 83%. Don't ask me why. So now I've got 18 millimeters is my glenoid track. Now I go to my humerus. Let's go up to my humerus. We don't really have a big area of depression, but let's pretend we do. So my humeral engagement area, let's pretend that this was a size of a depressed Hill-Sachs. And that measured 15 millimeters. If it's less than the glenoid size, that means we're on track. In other words, there will be engagement. There will not be engagement between these two structures when the patient moves their arm. So, in other words, said more simply, the risk of recurrent dislocation is lower. But if this track is wider than that 18 millimeters, in other words, if that Hill-Sachs measurement is over the glenoid measurement, then the patient is at high risk for recurrent dislocation. Many shoulder surgeons want that information. So the humeral measurement is a direct measurement, and I will show it to you on other large dislocating lesions. But I think this is a nice case to illustrate how you would measure on the glenoid side. So that is called on-track, off-track measuring for engagement in shoulder dislocations. Okay, now let's go back and scroll. We have an impaction injury of the humeral head. Let's look at it sagittally. There it is. It's almost impossible not to have some injury. The incidence of having no labral tear with a Hill-Sachs and a dislocation is about 1 to 2%. And those patients have severely stretched, deformed capsules. So now let's look at our labrum. We've got, yes, I can. So here's my glenoid cup. Here is my labrum. Here is my hyaline cartilage. My hyaline cartilage may dissect a little bit and undercut underneath the labrum just a tad. I've got a glenohumeral ligament, namely the inferior glenohumeral ligament that's purple, that blends with this fibrocartilaginous-like structure, and this together is called the labroligamentous complex. I've also got the remaining tissue, which is capsule, and together they attach to the scapular periosteum. They blend with the scapular periosteum. This relationship can also look a little bit different in that the hyaline cartilage may not undercut at all. It may just stop short right here. There may be an abrupt transition. So it doesn't go underneath the labrum. So sometimes it dissects a little bit underneath. Don't confuse that with a tear. Sometimes it goes right up to the stubby end and stops dead in its tracks. So now, what can happen to all these structures? You could tear right at the base of the labrum at the junction between the fibrocartilage. I'm going to color it in just to make it a little more dramatic. There's my fibrocartilage. So you could tear right here. And that would be a rim divot. The rim divot could go to the very base of the labrum, but not deep inside it. Some people call it a glenoid articulation rim divot or guard lesion. I could tear into the labrum, but not through it, so that the labrum starts to open and close a little bit like a triangle, right? The triangle's open, the triangle's closed. It becomes floppy, flounce-like, hypermobile, and may even hinge open on itself. It might even do this. Might even open all the way. That is called a GLAD lesion, a glenolabral articular disruption. I could tear all the way through the labrum and or involve the periosteum. If I did that, I would have a full-blown, soft Bankert. I have to tear labrum and or periosteum. I could tear underneath here, but not go all the way through. In other words, the superficial portion is preserved. This is still intact. My tear only goes to here, to this black line, and create a pouch. That's known as a Perthes lesion. Another name given to it is a single lesion. I could strip away the capsule and glenohumeral ligament from the labrum. That's another form of injury. If I did that with a labral tear, now I have a double lesion. I could also strip off all of the capsule and periosteum more medially. Now I have a triple lesion. And it can go on and on and on. What you can get in the front, you can get in the back. Now in the back, let me draw again. Switch color. In the back, the labral abnormalities tend to be a bit more chronic. Now, one difference between the capsular reflection in the front and in the back is the capsular reflection in the front inserts over here. It's a little more medial. Kind of blends this way. The capsular reflection in the back, right about here at the point of the labrum. So in the back, you could have all the same things that we described before. But very commonly, people are involved in sports and activities where they push. Men do push-ups, so do women. They do bench pressing. You push people in sport. And as a result, you jam the humeral head back. So you can get small, little peel-back lesions or reverse Perthes lesions that just go partially into the back of the labrum. And it's called peel-back, reverse Perthes, or Kibb's lesion. You could also strip off the posterior capsule but leave the labrum. In other words, the green separates from the orange. That would be called a pulpsa lesion. Posterior labrum intact, capsuloperiosteal sleeve avulsion. So this green stuff peels away, but the orange stuff stays on. So this would start to come off. You'd see a little space in between. So our black signal, our black color would be right over, you get the black up here for you. Black would be right in here. You'd have a little extra space there. Can you have that in the front? You sure can. It's called an ellipsa lesion. So you can strip off the capsule in the back and leave the labrum. You can strip off the capsule in the front and leave the labrum. In the front, what happens if you tear the labrum and it tumbles? Let me take a different color. It tumbles medially underneath the periosteum. It twists and turns, and it becomes subperiosteal in position. Now you've got an ALPSA lesion, an anterior labral periosteal sleeve avulsion, or anteroinferior periosteal sleeve avulsion. All right, let's look at our case. Let's start up high. Biceps labral anchor, intact. Superior glenohumeral ligament, intact. Triangular shaped rotator interval with coracohumeral ligament, intact. Now, as we go from top to bottom, the labrum should get bigger. That's a rule. That's the rule I alluded to in my initial introductory slide. Labrum should get bigger, blacker, more triangular, more consistent, more visible. It doesn't. As you go from top to bottom, the labrum should be in the front, slightly bigger than the labrum in the back. It's not. As you go from top to bottom, the labrum should be more firmly attached to the glenoid. It's not. There's a defect or divot at the base of the labrum. The labrum is separated from the glenoid. Is there a piece of bone off? No, there's not. There's no bony bankert. Has it ruptured all the way through and through? Yes. All the way through, from posterior to anterior, there's a soft bankert. Has the capsule become detached from the labrum? It sure has. It should be a nice, thin, consistent linear structure abutting that labrum, and then it becomes this squiggly, wiggly line. That is irregular capsular torn tissue. The condensation of that capsule is the MGHL. So we have a capsular injury, capsular peeling from the labrum, labral peeling from the glenoid. It's at least a double lesion. Do we have periosteal separation? We sure do. Look at all that dissection of fluid and blood along the medial scapula. This is all elevated, torn periosteum right here. So periosteum off, labrum off, capsule off, triple lesion. In the back, everything's just fine. The capsule is coming off the apex of the labrum. Actually, that's a misstatement. Everything isn't just fine. He's a weightlifter. He's a bench presser. He's got a little crack in the posterior labrum. They all do. Asymptomatic. It's healed. It's scarred. Yes, it's a chronic labral tear. It's incidental. Put it in the body report. Otherwise, ignore it. Are there any questions about this case? All right, let me go to part 2 of this case. Well, usually if the patient has the question is, what is the clinical implication of a double lesion and a triple lesion? And the answer is, if the patient has a capsular tear or a major capsular injury, then there's a greater likelihood that there'll be an imbrication done or a capsulorrhaphy, and the procedure becomes more complex, and the clinician is more likely to want to do it as an open procedure rather than as an arthroscopy repair for that instability. So it does have meaning. Now I'd like to go to the coronal projection sort of as part 2 of this case, because it's a lovely case. We said there was an anterior labral tear. But in the axial projection, you are en face to the axilla, right? So it's hard to see what's happening top to bottom. So let's look at what's happening in the bottom. That line is periosteum that's pulled away. Now, if we had an ALPSA lesion, an anterior-inferior medialized piece of labrum, it would be sliding underneath that periosteum. It's not. But we have another finding. Our anterior labral tear has axillary extension. How do we know? Because you should never have a line that goes all the way out the medial aspect of the labrum. There it is right there. I'm going to blow it up. You should too. So the axillary portion of the labroligamentous complex is also detached. It's not diastatic, but it's detached from the glenoid. No bone. What about the ligament itself? The ligament itself is intact. If I tore this part of the ligament, what's that called? Anybody know what that's called? A haggle, a humeral avulsion of the glenohumeral ligament. If I take a piece of bone with it, it's called a bagel, a bony haggle, or a bee haggle. If I take the ligament off the labrum, not the labrum off the glenoid, but the ligament off the labrum, it's called a gaggle, a glenoid avulsion of the glenohumeral ligament. If I tear both sides, this side and this side, I now have a floating IGHL, or an anterior inferior glenohumeral ligament avulsion, called an IGL. Or I could just chop it down the middle, in which case I would say I have an inferior capsular disruption. Or I have plastic deformation. It's hanging down like a big lariat, in which case I would say I have failure or insufficiency of the inferior capsule. And by the way, yes, he does have a weightlifter's small slap lesion, a tiny little fissure superiorly. They all do. And that would go in the body of the report. Incidentally noted as a small supero-posterior weightlifter's slap lesion, likely slap 1. Incidentally noted as a chronic posterior healed, scarred labral tear in the body of the report. In the conclusion, triple lesion with a labral tear from 3 o'clock into the axilla with a torn capsule and periosteal stripping. No bony component. Next case. Let's start with our axial. Since we only have 3 minutes to break, I won't take you through the entire search pattern. But it is fortuitous that the findings are conspicuous in our first axial projection, which is how I start reviewing most of my exams. The humeral head is centered. The glenoid cup is a little flat. The cartilage is nice and thick and normal. The humeral head is nice and curved. The cuff tissues are normal, and the obvious finding is a high signal abnormality anteriorly. So we have the same differential diagnosis we had earlier in the hip. Are we dealing with a ganglion pseudocyst from capsular insufficiency or a rent or a tear in the rotator cuff mechanism, or is it coming through the labrum? And that will be a story for after your break. Case 151. This is a 31-year-old volleyball player. She had pain after serving a volleyball. We've got an axial that demonstrates a proteinaceous water signal intensity cystic mass in the rotator interval. Is it coming from the capsule or is it coming from the labrum? You decide. Now, sometimes you are inhibited by spatial resolution. In other words, the slices are too thick. Sometimes you're inhibited by contrast resolution. In other words, the crispiness of the image does not allow you to follow the detail of a sub-millimeter sized object. And we're looking for a tiny little tail. So let's keep scrolling. There is a small tail, but I think it's challenging in this projection with this contrast resolution to figure out if that tail is diving into the capsule or into the labrum. Let's go to another projection. Let's take the coronals. I'm going to blow them up. And let's scroll. Let's find our cystic mass. It's complex. And see where it goes. It goes right there, doesn't it? I'm going to put a punctuation on it. I know Alex doesn't like the color purple. How about the color orange? Thank you. Now follow it forward. There it is. It's blowing up. It's getting bigger. It's getting bigger. It came from the anterosuperior labrum, right at the anterior margin of the biceps labral anchor. It dissected into the rotator interval and finally became a pseudocyst of the rotator interval. So this would be a SLAP 10. How many SLAPs are there, you say? Well, there's probably 12. The last two we described. But let's talk about the first 10 very quickly. Type 1, fraying. We see this in young, especially male weightlifters all the time. They are usually asymptomatic, and it shows up as scuffing on an arthroscope. Type 2, more of a well-defined fissure. In adults that don't do a lot of overhead sports, you see degenerative SLAP2 lesions all the time. If they are acute or traumatic, they can produce cysts, and the cysts can result in entrapment neuropathy. A 2A would be anterior, a 2B would be posterior, a 2C from anterior to posterior. SLAP3, a bucket handle tear. You basically separate the labrum into two pieces, and it folds like origami, and one of the pieces may droop into the joint. If you look down on the labrum from the top, it looks like a circle or a Cheerio. It looks like a ring with a hole in the middle. Type 4, similar to type 3, except that there is longitudinal extension into the biceps. Type 5. Type 5 is a superior tear with anterior-inferior extension with Bankert-like qualities. In other words, there may be an anterior-inferior Bankert lesion associated with it. Type 6, a flap lesion. In other words, a tear, but a piece comes off and droops into the joint. Type 7, dissection into the anterior capsule or middle glenohumeral ligament. Type 8, perhaps the second most common symptomatic type. Superior and then rolling around the back, posterior-inferior, seen in weightlifters, pushers, contact athletes. Type 9, almost 360 degrees of involvement. Type 10, dissection into the rotator interval with or without a cyst or a pseudocyst, sometimes involving the superior glenohumeral ligament. This is a type 10. Next. Injured 2 weeks prior to the MRI. He has pain and diminished range of motion. Rather young, muscular person. Now, a common mistake in overhead athletes is to read the superolateral humerus pitting as a Hill-Sachs lesion. Yes, he had an injury, but he did not have a dislocation. This pitting can be dramatic. Sometimes these pits can be 2 to 3 centimeters in size. It can be very large. The key is that there's no history of instability or dislocation. They simply have pain when throwing. These are impaction troughs that occur. Let's look at them in the coronal projection while you're scrolling. Here are a few in the back, postero-superolaterally. They occur with the arm in the cocked position as this humeral head contacts the normal acromion in extremes of abduction and external rotation, so-called a-bear position. Another way to tell this is not a Hill-Sachs, besides the history, is the fact that it's well-defined, it's etched, it's edged, it's corticated, as opposed to something more acute in which you'd see a pattern of more confluent edema and swelling. Now, that being said, even though this person is an impinger, he is a thrower, he does have all the typical large pits and irregularities of an overhead athlete, he does have a labroligamentous problem. It's not easy to see in the axial projection. In fact, athletes have big labra. He does. Athletes have big IGHLs, especially the anterior band. He does. But his abnormality is not anterior. It's inferior. Let's put up the coronals. Now, you've had a few rules of thumb. One rule of thumb is variability of the labrum superiorly, consistency inferiorly. Go from top to bottom, labrum gets bigger, labrum gets blacker, labrum gets bigger than the posterior labrum, front to back, as you go down. Rule number 1. Rule number 2, when you go from front to back, sulci, clefts, variations decrease in the posterior quadrant of the shoulder. So if you've got a questionable area of signal change in the superior labrum and it gets bigger as you go backwards, it's probably real and probably relevant. Rule number 3, in the inferoaxillary labrum, you should never have a line that goes all the way out the medial side. And we do. And a swollen IGHL and periosteum. Let's blow it up. So what are we going to name it? Clinically, what do you think it would present as? Clinically, it would present to an orthopedic surgeon as a ligamentous sprain. What we call it on MRI, a ligamentous injury, a partial thickness injury or tear of the inferior labroligamentous complex. Patient is not dislocated. They've subluxed. So what's the treatment? Rest. Look at the attachment site right here. There's a very small tear right there at the labroligamentous interface. And the rest of the ligament is swollen. It's a non-surgical shoulder. An IGHL clinical sprain as an inferior area of swelling and microtraumatic injury. Let's do another one.